You're listening to This Week in Cardiology from theheart.org on Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or, Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for August 21st, 2020. This week, COVID, diversity, clinical research, the sub-Q ICD, and ECGs. First, COVID. Yesterday, we hit 5.7 million cases in the U.S. Now, U.S. deaths 2 weeks ago were 170,000. This week, they were 176,000. So the rate of rise has actually fallen slightly to 1.03x. The bad news here, of course, is with schools. Colleges particularly. Numerous colleges have tried to bring in students but had to go virtual due to clusters of cases. But today I'm going to say a bit of good news. My colleague at theheart.org Medscape Cardiology, actually the editor-in-chief, Eric Tobel, tweeted this week that SARS-CoV-2 is evolving very slowly. That makes neutralizing antibodies and vaccines have a better chance to succeed. All of the recent reports also support a solid B antibody and T-cell immune response. Third, there are no documented reinfections. Now, Professor Natalie Dean added that serious illness in kids is very rare. So this is good news. On the home front here in Kentucky, our hospital has not seen a significant rise in COVID admissions, and the mortality rate is plummeting. We see fewer older and more vulnerable patients, presumably, I think, because we've learned how to protect them in the community. Also, the number of patients that are turned into zombies from early intubation is markedly reduced. My colleagues in the ICU think steroids are helping, and possibly even remdesivir. No, of course, we're not out of the woods. The days of having 30,000 people at cardiac meetings seem far off, but perhaps there is a light flickering off in the distance with the pandemic. Second topic is diversity. Now, my trusted editor of many years, Tricia Ward, has an outstanding Q&A piece with interventional cardiologist Quinn Capers from Ohio State. The title, Diversity, Not Test Scores Equals Quality in Medicine, tells you what they talked about. Dr. Capers isn't just an interventional cardiologist, he was also Dean of Admissions and has been a leader in promoting diversity in medical education. My favorite quote from Dr. Capers regarding test scores and admissions is this. He says, there has never been any evidence that somebody who gets 90% test questions right will be a better cardiologist or surgeon or family doctor than somebody who gets 80% of the questions correct. So when they say, I just want the best, they're clinging to a metric that doesn't measure who is the best. Now, after decades of practice and years of observing academics, I 100% agree with this statement. Test scores and publications are not nothing, but their correlation with being a good doctor or good surgeon is extremely weak. Now, full disclosure here, I don't know if I've ever said this on the podcast, but I had truly terrible SAT scores, and I had only average MCAT scores. I succeeded because of mentors and because a college and medical school took a chance on me. So how many minority students don't get the chances that I had? Another notable part of the Q&A was that Dr. Capers explained the retraction of the controversial Dr. Wang paper on diversity in the Journal of the American Heart Association. Capers noted that that article was not retracted because the author's views were controversial or hurt people's feelings. The bar for retraction is that the author falsified data. So I look forward to Dr. Capers' rebuttal letter that will be published. Diversity, this topic, brings me back to my friend Andrew Foy's comments on diversity. Foy is a white cardiologist whose hobby is promoting boxing. He strongly believes that having more Black and Hispanic mentors would do wonders for young people. And I agree with that. Third topic is clinical research in the COVID era. Now, I don't know how it is at your place, but recruitment for clinical trials at our place is a lot harder during the pandemic. We have had to close out participation in a drug trial that started just a few months before the pandemic hit. Mitigation and social distancing and work from home made it impossible to recruit for the trial. A research letter published in JACC confirmed that our experience is typical. The authors, led by heart surgeon Dr. Mario Gaudino from Cornell, used data from clinicaltrials.gov to study the effect of COVID-19 on ongoing non-COVID trials. On average, about 640 trials per month were stopped in the 3 years before the pandemic, but during the pandemic it was nearly ninefold greater at 5,800 trials stopped per month. The majority of the trials that were stopped during the pandemic had non-governmental funding. The number of trials stopped per month increased significantly with time during the pandemic. Now, in a news story, co-author of the paper, Dr. Deepak Bhatt, said that he knew of several cardiovascular trials that were paused and some were permanently discontinued. It may be a while before we fully appreciate just how much information was lost and how much might be salvaged, he said. Now, I see two ways to look at this issue. Of course, the interruption of and termination of trials is problematic because of the lost information. But on the other hand, tell me if you think I'm wrong about this. The study found that 95% of the trials had non-government funding. Now, many of these were going to be industry funded. Well, some industry-funded trials are worthy endeavors. But sometimes I wonder if not so small numbers of sponsored studies have marketing rather than knowledge as their main goal. As the late Dr. Doug Altman famously said, we need less research, better research, and research done for the right reasons. So I wonder, a contrarian view of this would be that maybe the pandemic will help trim the fat from dubious research. Time will tell. Next topic is the subcutaneous ICD and the Praetorian trial. Now, at Heart Rhythm Society in May, the Praetorian trial investigators presented the first RCT of Boston Scientific's subcutaneous ICD as a late-breaking clinical trial. I covered it then on the podcast, but earlier this month, the New England Journal published the results, and it's always good to get the full paper to review. I'm actually working on a written column on this trial. And yes, of course, I will have a skeptical take about this new device. But let's just do a quick review here. The sub-Q ICD has a lead outside the ribs and a can on the left lateral chest. The lead is close enough to the heart to sense the cardiac signals. In the event of VT or VF, defibrillation occurs with the energy going from the can in the left chest to the leads around the heart. The point of the S-ICD is that it has no leads in the vein or the heart, and the theoretical advantage is that this could avoid lead complications that are known to accrue over time with the standard transvenous ICD. Things like infection, rise in threshold, fractures, insulation breaks, recalls, etc. Now, the downside is that without a lead in the heart, there can be no bradycardia pacing, no overdrive anti-tachycardia pacing, and without leads in the heart, sensing is more challenging. Double counting of R and T waves have been noted, and of course this leads to inappropriate shocks. The Praetorian trial used a non-inferiority design and a safety primary endpoint, not an efficacy primary endpoint, safety. The safety endpoint was a composite of lead complications and inappropriate shocks. They had about 400 patients who were randomized to either the S-ICD or transvenous ICD. Importantly, patients were excluded if they had a pacing or CRT indication or if they had regular monomorphic VT at a pretty slow rate of less than 170. The top-line results were that the identical number of patients had primary safety outcomes in each group. This met non-inferiority, but not by much. The upper bound of 1.39 of the confidence interval was quite close to 1.45, which was the agreed-upon non-inferiority margin. But the two components of the safety endpoint diverged. Lead complications favored the S-ICD, but inappropriate shocks favored the transvenous ICD. Notably, appropriate shocks were higher in the S-ICD group because the device cannot painlessly terminate VT. Appropriate anti-tachycardia pacing was delivered in 13% of the patients in the transvenous ICD group, and of that, it was painlessly terminated in 55% of all treated episodes. Now, the authors concluded, rightly so, that the two devices were non-inferior. And I don't want to give everything away in my written commentary, but let's suffice to say I'm not convinced. Well, first of all, why should we study just safety? Now, we know transvenous ICDs reduce mortality, but the S-ICD is dissimilar enough to warrant an efficacy study. Consider that a recent German study, which I will link to, found that 1 in 5 patients with an S-ICD did not defibrillate when they came to be tested at a generator change. Now, one theory as to why DFTs increased is that a gain in fat around the device could increase the impedance enough. Other colleagues have mentioned this problem to me as well. Another issue is a lead complication like dislodgement the same as a wide-awake shock. I would argue that shocks are way worse. Now, to be fair here, Boston Scientific has a new sensing algorithm in the S-ICD that will likely reduce oversensing and inappropriate shocks. Now, a couple of specific issues with this study. First, the results barely met non-inferiority, and 38 patients were lost to follow-up. I realize that the fragility index is in a bit of disfavor these days, but if you have a trial that's very close to being not significant and you have many missing patients, that I think is an important issue. But the biggest weakness of the trial is that it was only 4 years. The S-ICD is promoted for its ability to prevent long-term lead complications, so there is nothing in Praetorian that supports that contention. And while iterative improvements in the device and the implant procedure will make the S-ICD better, I feel like we need more data. You don't often get 2 chances at defibrillation, and that transvenous ICD sets a high bar of evidence. Final topic are ECGs. Now, 2 news stories published on the Heart.org Medscape Cardiology highlighted the past and future of the ECG. Before I tell you about the 2 studies, let me set out a severe bias. That is, I love the ECG. Learning to read ECGs is one of the reasons I got into electrophysiology. The test is painless, fast, and inexpensive, and those 12 simultaneous looks at cardiac activity can tell you a lot about the patient. From the basics like rate, rhythm, and axis to the various patterns of QRS and T-wave morphology, you get a gestalt about the patient's status. No, it's not a perfect test, but over time and with practice, you can learn to use the ECG to help you, not merely to rule in or rule out an MI. Now, the first news story covered a report on a quote-unquote foolproof way to diagnose narrow complex SVT on an ECG. This from hospitalist Megan Mary Walsh. Now, I saw the foolproof in the headline. I wondered what her technique was. Turns out it was good old classic systematic thinking. Start with rate, then look at regularity, then P-wave axis, then use these to narrow the differential diagnosis. It sounds so simple, but more and more I see people not follow this basic approach. No, it is not AFib if there are organized P-waves. No, it is not sinus tachycardia if the P-wave axis is superior. It's probably atrial flutter. What's more, an older patient does not have a resting heart rate of 120. So these are basic clues. Now, Dr. Walsh has a beautiful algorithm, but the only thing I would add to it is this. Don't look at the computer reading until after you have read the ECG. Too often, the computer leads people astray. So if Dr. Walsh's technique rekindles the past, the second study, published in Circ EP, signals the future. The Mayo Clinic doctors studied 1,600 patients who came to their emergency department for dyspnea. They then applied an AI, artificial intelligence, ECG algorithm and their goal was to identify left ventricular systolic dysfunction by echo in the next 30 days. Get this, the AI program identified low EF with an area under the curve of 0.89 and an accuracy of 86%. That actually outperformed the BNP. Now, I know a contrarian would say one doesn't need AI to predict a bad EF. You could just do an echo, or soon a point-of-care bedside echo to learn the EF. And yes, of course, now that is true. But this is the beginning of the AI work on ECGs. You have to open your mind to what will be possible with further iterations in the future. Now, perhaps the reason I love the Mayo team's work with AI prediction in ECGs is that a study like this confirms what I feel in my heart about the ECG. Namely, that you can see things from the pattern of an ECG. You can feel what's wrong with the patient. You can look at an ECG and you can say, that is a bad heart. Now, the human brain may deduce things in a different way than a computer, but the end result is the same, a clue, a potential prediction. So that's it for this week in cardiology. As always, I am grateful that you listened. Thank you. And remember, please, if you like this podcast, please consider giving us a rating, subscribing, writing a review, telling a friend. All of these things help other people find us. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.